we have our gloves, we have 1 milliliter of EDTA treated blood, we have our 15 milliliter vacutainer, got a syringe to draw up our blood, we have the 9 milliliters of a 10% formalin, have our microscope cover slip, and then we have our microscope slides as well as our counter stain. So we are going to take 1 milliliters of blood, put it in our vacutainer, and then add the formalin. And then you want to put our cap back and invert that several times. That way we get it thoroughly mixed up. And then we're going to centrifuge our sample for 5 minutes between 1,000 and 1,500 rotations per minute. Our centrifuge has stopped spinning. We are going to just very carefully remove our vacutainer and make sure not to disturb the whitish pellet at the bottom. We're going to use a long pipette to remove the supernatant from the top. And while we're doing this, just be very careful not to remove or disturb your pellet at the bottom. Okay, now that we've removed most, if not all, of our supernatant, we are going to get just a single drop of our methylene blue. And then we're going to add it to our pellet. And then we are going to just very gently mix that little white pellet with the methylene blue, and then we'll take a drop of that and place it on our glass slide. Place a cover slip over the top. Use our modified knots method for the concentration and identification of microfilaria, specifically to differentiate the heartworm Dirofilaria mitis from the non-pathogenic microfilaria dipet for short. The 4x objective, and then move to the higher power of 10x objective, which will be our final power. We've got it focused on our 4x. Now we're going to move to the 10x objective. Look for Dirofilaria mitis. And I do not see any Dirofilaria mitis. Simple fecal flotation. We have the microscope slide, the cover slip here that we're going to put on the top of our meniscus here in a minute. We have our fecal cup, our fecusol. We've got about 2 grams of fecal sample. We also have a piece of gauze. So you need about 2 grams of your fecal sample to go ahead and mix up with the fecusol. And then you want to really mix it up. So I've got this tongue depressor. Just try our best to get it off of me. And then we're just going to really mix it up as best as we can. We do the fecal flotation for for several reasons, but it's based on a method of the differences in specific gravity. So the flotation solution has a specific gravity that's higher than the specific gravity of intestinal parasites in different life stages. So usually the intestinal parasites have a specific gravity between 1.1 and 1.2 grams per milliliter, and the Fecosol solution is greater than that. That way we can hopefully see some intestinal parasites that are present in the fecal. Strain it. And put our strained material in there and do the same thing, just cause a little lip on the cup, pour it into the fecal cup. We're going to put our second piece in here, stool all over the counter, and then you want to put the fecal solution in your fecal cup until you form a meniscus. We're going to take our cover slip and just gently place that over the meniscus. Run our test for 10 to 15 minutes. The fecal float is done setting here. We're going to take the cover slip and put it on our microscope slide. For fecal flotation with centrifugation, we are going to be doing this test today because it gets more ova and cysts in a shorter period of time than as opposed to your simple centrifugation or simple flotation. We only need about 2 grams of the fecal sample. Make sure it's as fresh as possible, and then we have our 2 tubes that we're going to be centrifuging. We also have our straining cloth. It's just a piece of gauze, and we're going to be straining this over the cup instead of directly into the tube. That way we can catch more of the sample and put that into the tube. We also have our Fecosol solution that we're going to be using to help strain the sample, and then we've got our gloves to stay clean and handle our sample properly and safely. The 2 grams of our fresh fecal sample. I've got my stool sample in here, and I've got my Fecosol that we're going to be mixing it up with. And then we'll go ahead and strain the sample. You can use a tongue depressor. Just want to make sure that we strain it really, really well before we put it in the centrifuge. Demonstrate my best here. When I'm doing this, I'm just very lightly pouring this into the cup, and it's just slowly straining through that gauze. Take our container, or vacutainer that we're going to be centrifuging this piece in. And we do want to make sure that our centrifuge is balanced, so I'm going to pour equal amount of the Fecosol up to the, try and get it as close as possible. That way we can make sure that the centrifuge is balanced and it spins properly. Traditionally, you want to use a tabletop centrifuge that can accommodate rotation buckets. That way we can put a cover slip over this, and we would actually fill the fecal solution all the way to the top. for both of these. We would put a cover slip on here. We don't have a tabletop centrifuge, so we're going to use our normal one. We're going to spin this down for 5 minutes. Our centrifuge has stopped spinning. We need to just very carefully remove our tubes. That way we don't disturb the sedimentation at the bottom. And fill the top of the tube and with the fecal salt solution until it forms a meniscus at the very top. We've got a nice meniscus right here. Just let that spread, and then we'll go ahead and start our timer for 10 minutes here. Our sample has the cover slip sitting on the meniscus for 10 to 15 minutes. We're going to place it on our microscope slide. Get direct fecal smear. This involves the least amount of material needed. It's one of the simplest fecal tests that is available. The only disadvantages to the direct fecal smear is that it just uses a very small amount of fecal matter. So if we have a low parasite presence, it can be really hard to detect or pick up those parasites on the rapid screen. So it's always best to pair this with other tests as well, but it helps to get a quick diagnosis. So for this procedure, is our fecal salt solution. We have our fresh stool sample. I'm using a cotton tip swab to help collect some of the fecal sample and roll it on the slide. I've got a syringe here just to more carefully and more controlled put drops on the slide. I've got our microscope cover slips, and then of course we have our microscope. So we're going to go ahead and get started. We want to try and use equal amounts of the stool and the fecal salt solution here. So first things first, I'm going to take out the plunger. And just put a small amount of the fecal salt solution in here. And that way we can use it for our test. Okay. This very, very tiny amount here on the end of the collection container is more than enough of what we need. So we're going to put a couple of drops fecal salt solution on our slide, and then we're going to just gently roll our fecal sample from our cotton tip swab on. It's thin enough to actually look through. You should be able to look at like newsprint, just letters, through the slide. If it's too thick, you won't be able to evaluate it microscopically. And then the only other downside to the direct fecal smear is that extraneous fecal debris can be confused with parasitic material. If you've got any large debris on here, go ahead and remove that before you put your cover slip on. Once you've got that thin film, go ahead and place your cover slip on here and then start at your lowest power objective. To do our fecal sedimentation, for this test we have a tongue depressor. We've got a syringe to control the amount of tap water in this cup while we are mixing the fecal sample with the tap water. We've got a fresh fecal sample. We're just going to be using about 2 grams of that fecal sample, so not very much at all. And then I've got 2 cups back here. One of them is going to mix the fecal sample with the tap water, and then the other one we're going to be straining that mixed fecal sample and water into. We're going to be using our gauze just like before to strain that solution, and then we have our 2 vacutainers over here that we're going to be putting the strain solution in. The other one we're going to be using to help balance our centrifuge. It's generally better if you can get a tabletop centrifuge that allows for the accommodation of rotation buckets. What we do have a fixed angle centrifuge, and so we'll work with that today. We also need a microscope cover slip for the end of our process, and then of course we'll need our microscope slides here. Very small amount of fecal sample, just 2 grams. That you mix it really thoroughly. One of the major downsides to this test is that it is very laborious. It takes a lot of time, take a lot of materials. One of the primary parasites and ova that we're looking for in the fecal sedimentation is things like fluke worms. The sedimentation is mainly used for testing with ova parasites that are just too heavy to float. So our fecal flotation would be a good test. Our sample has strained. We can go ahead and pour it into one of our vacutainers. Now we're ready to centrifuge. Now that our sample has been centrifuged, we just need to be careful when we're removing the centrifuge sample. That way we don't disturb the sedimentation that's at the bottom of the vacutainer, because we're going to be needing to pour off or use a pipette to remove the supernatant at the very top. And you can see some of that sedimentation there at the very bottom. Pipette off a lot of this supernatant up here until we get to the sedimentation at the bottom. That sediment, I'm going to just put a drop on there. And then we're going to put our cover slip like that. Now we're ready to look at that fecal sedimentation under the microscope.
Okay, so we're going to do our free catch on Murphy. We have some of our supplies here, including a syringe to drop the collected urine. We've got just a clean baby wipe. We've got our ladle to catch the urine, and then I've got some gloves. That way I can stay clean as well. So the first thing that we're going to do is we're going to wipe off the prefuse and try and remove as much of the contaminants as possible before we collect this sample. Catch a urine sample midstream. That way, hopefully, the contaminants have been partially flushed out. We get as little contaminant as possible. Good boy. All right, and now we've got plenty of the voided urine sample, so we're going to use our syringe to collect the sample from our collection container. Now we have our urine-free catch sample. Look at the physical characteristics of Murphy's urine. To look at the urine within 30 minutes to an hour after you collect the sample. Look at the clarity of the urine. So you typically want to hold it up to a background with some lettering. And his urine's pretty clear. Waft the urine, it smells pretty normal. It doesn't smell like it has a lot of ammonia or any kind of sweet smell. The color, it is a little bit like a straw urine. This isn't first morning's urine, which would be best. First morning's urine is best because we don't have that kind of diet impact on the urine sample. It's also most concentrated, and it's our best chance of finding formed elements with first morning's urine. The only downside to free catch is really that we can't use it for culture and sensitivity tests because of the high risk of contamination. Use free catch because It's the easiest, it's the least stressful way to catch a urine sample when we need it, but an increased likelihood that you'll have increased white blood cells because of the contamination from inflammatory lesions just along that distal urogenital region. What we want to check is the specific gravity, and so we do that with our refractometer. If we're concentrating well, so you'll put a single drop on the plate, gently close the lid, and then you'll point it up towards a light source. And his specific gravity is 1023.
Ear cytology, we've got a couple of items here. We've got our glass slide. We have our cotton tip swabs for each of the ears. We've got a syringe to collect a small amount of the 0.9% sodium chloride, and that's just to moisten our cotton tip swabs. It's better for collection as well as helps minimize any damage to the ears. So we're going to moisten those before we get started. And we do our ear cytology for patients who present with scratching, have any dark debris in their ears, the ears have a bad smell to them. Go ahead and mark our right and left on the frosted side of our slides there. When we get our samples, we're going to get it from the horizontal canal instead of the vertical. Our dog's ears are shaped like an L, so we have to get this horizontal sample. And then you just want to gently roll your ear sample across the slide. Make sure you get your sample evenly. It's important to do both ears because you can have a completely different ear infection in both of them. You need to know what to treat for. Perform the ear cytology when an ear infection is suspected. Every time you do a recheck for ear infection, as well as for non-responsive and recurrent ear infections. You do need to know when you need to continue to treat or stop treatment. And we've got a good sample for both of our ears. For his ear cytology staining, we've got our 3 different stains: 10 dips, 15 dips, and then 20 dips. You can also leave them in there for 10, 15, and 20 seconds. And you want to make sure that your sample is completely submerged. Use just sterile water. Just gently wash it off. And just gently dry off the other side of the slide that we're not using. So we're going to start off with the lowest setting, which is our 4 objective, and then move to a higher power at 10 objective. And then we are going to use some immersion oil.
Alright, we are going to do our urinary catheterization. This is our patient Murphy. We've got a couple of different tools today. We have our syringe. It's a 12 ml syringe, so we can pull up our urine from the catheter. We have a 5 and an 8 French urinary catheter as well. We'll just kind of see how big the opening is. We've got some sterile lube that we're going to open, keep our procedure as sterile as possible, and then we also have a couple of just baby wipes here to clean off the prepuce with. That way we get as little contamination as possible. So Miss Cameo is going to go ahead and extrude the penis, and then we'll clean his prepuce. Can you come over here? I'm just gonna get like that angle. He's like, Mom, what are you doing? Man, we're struggling today with this.
Well, maybe we just don't know how to do this, guys. Murphy, put your penis out. There, buddy, go.
And so we're just going to gently clean the tip of the penis a couple of times. Just make sure it's as clean as possible before we try the catheterization. Good boy, Murphy. Good boy. Okay. And then we need to open our sterile lube. I feel like he needs the 5. And then as far as measuring for the placement, you want to do the caudal portion. You want to measure up to the caudal portion of the bladder. So it should be about right in here. So really, we should have quite a bit of excess with this catheter.
Yeah, good boy.
Good job, buddy. Okay, and then get some lube on the tip of here. Good job, buddy. Good job. And then we're just going to very gently move it through. And then before I reach the bladder, I just want to put our syringe on there. Good job, buddy. And just very gently and slowly move it through there. Okay.
Good boy, good boy.
Good job. Good boy, Murphy.
Oh, you gotta pee.
It's okay, Murphy.
Alright.
Good boy. Good boy.
Being good boy. What is this in there?
I don't know why we didn't put in the urine. Okay.
Good boy, Murphy. Good
job, buddy.
boy.
Okay. That's different.
And right now, all that I see is some big clumps of skin cells. I don't see any bacteria or yeast. So I'm gonna move to my 10 objective. Use some of my immersion oil on here. And you really just need 1 or 2 drops. I'm seeing some waxy debris and wax in the ear in small quantities is normal. cytology. Present themselves with alopecia, hyperpigmentation, chitin acne, pustules, things like that that would indicate the need for a fungal culture. Bought our gloves to modify test medium of our sterilized hemostats. Toothbrush method is used if our patient presents without lesions, non-classic lesions. Pluck about 10 to 20 hairs from the periphery of new or expanding lesions. You could also use a Woods lamp to see if the dermatophyte will fluoresce under it. There's about a 50% chance of them fluorescing. Okay, so we've got our hair sample here, and now we're going to put it in our media, and we're just going to very gently press it into the media. But we're not going to bury them. To properly label your samples with the patient's name and then the date of inoculation, that way it doesn't get confused with any of the other patients who we might be doing at that same time. We have our lactophenol aniline blue. We have our culture that's been incubating for 21 days now. We have just clear cellophane tape, and we've got our hemostats because we'll need to do an impression at the colony site of incubation. And then the first thing we're going to do is just put a very thin line of the phenyline blue on here. I'm going to open our culture, and you can see we don't have any medium color change. It doesn't appear that any colonies have formed, but we're going to look at this under the microscope to be sure. So we're going to take the sticky side and just very gently press it against our media. And that's going to be at the site of inoculation. And so now that we have our sample, we're just going to be very careful. Cut it down the middle top section. And that way the tape will be acting as our microscope cover slip. Place our tape just right on top of the lactophenol blue that we have, and then we're going to look at it under the microscope under the 40 objective and look for spores. But I am not seeing any spores, so it looks like our patient does not have any signs of dermatophyte. For our skin scraping, we have our scalpel handle, our scalpel blade, some gloves, 40 blade electric clippers. We have our microscope cover slip, microscope slides, and then we have our mineral oil. We do a skin scrape if we're suspecting ectoparasites. You want to choose your site of skin scraping based off of the freshest lesion where we might suspect that the ectoparasite is. And then as far as the depth of how you should scrape, depends on what kind of ectoparasite we suspect we have. So for Sarcoptes, they're burrowing mites, so we would want to scrape until we get a little bit of fresh blood. We're going to perform a very shallow skin scraping for parasites that we suspect are just kind of on the top of the skin. We just want to save a small area of hair. We're going to be doing a skin scraping like that. And then we're going to arm our scalpel handle. Before we start scraping, we're going to put a drop or two of the mineral oil on our slide. And then we're also going to put some on our blade. And then we're going to hold our blade just perpendicular to the skin. We're doing a very superficial skin scrape. And then we want to just brush it in the direction that the hair is growing, and then we'll get our skin cells. Going to just place our sample on the slide here and then go ahead and do a second scrape. We've got our sample, so we'll go ahead and place our cover slip on there and then look at it under the microscope. Look at our skin scrape. Now that we've obtained our sample, we're going to be using just the 4X objective. I'm seeing quite a bit of debris and epithelial cells, but no surface dwelling ectoparasites.
Necropsy is a thorough examination of the external and the internal organs of an animal's body, as well as to determine the disease process or processes that led to an animal's death. We can also use a necropsy to determine the effects of treatment on the animal's body. You really want to perform the necropsy in an area that's not usually used for surgery or treatment. You want to be able to move around your patient during the necropsy easily, as well as be able to clean the area, disinfect it, and then dispose of any items necessary during the necropsy. Personal protective equipment for necropsy involves many items. You can use an apron, you can use a lab coat. We choose to use a removable long-sleeved smock. That way we can take it off when we're done with the necropsy, disinfect it, clean it, or destroy it if we need to. We have our protective eyewear. That helps to avoid any contamination and protect our eyes from any bodily fluids. We've got our gloves here, which will help us protect us against any formalin splashback that we have when we're using it. Formalin is a known carcinogenic, and it also has, it's very irritating to the skin. We also want to use this to protect our skin if we have any cuts, things like that, from getting any transmissible diseases. We want to wear our mask to help protect from any aerosolized infectious diseases as well. And then we've got booties. This is usually used more in large animal necropsies to protect your shoes from contamination. The instruments include a variety of different tools, such as our necropsy knives. You want to make sure that they're very sturdy, they can be sharpened, they're not going to break easily. We also use nail trimmers instead of pruning shears. This helps to break through the ribs when we're opening the rib cage up, as well as to cut through other bones. For our tissue biopsy samples, we're going to be collecting with the Adson tissue forceps. They hold delicate tissues, don't pierce or tear through them. And then to hold our tissue back, such as when we're opening up the abdominal or thoracic cavity, we're going to be using our rat tooth forceps. It's important to use a scalpel handle with your blade when you're opening up the abdomen. That way you stay safe. And then we're also going to be using our Mayo scissors to continue to cut through thicker tissue. That would be hard with our blade and scalpel handle. We also have our biopsy jars here that contain formalin. We also want to make sure that with our samples we include the history in that, so if the patient died of unknown causes, what our findings are during the necropsy, vaccination history.
We'll be performing a necropsy on this dog, and I am Jessica, and this is Dr. Anna Coffin.
Hi. So first off, we're going to do our external exam on the animal and list any abnormalities. So the main thing that you want to be looking for would be any external bruising on the skin. So you can look at the conjunctiva, look on the lips to see if you see anything, any blood in the mouth, any blood coming out the nose, any bruising. This dog does have a small laceration on its abdomen here. Also has ticks. You want to notate any type of parasite seen. So that's pretty much it on this dog. It is an unneutered male. And then what we're going to do is go ahead and open up for necropsy. And we just do a midline incision. Notate if there's any blood in the in any of the orifices. So nothing visible blood-wise in the thorax. There's no fluid, excessive fluid in the abdomen. Now this is abnormal on this dog. These little white dots. We'll take some samples of that, but no fluid or blood in either cavity that we see. You also want to take a good look at all of the lung fields, see if there's any nodules. Some of these changes that we're seeing in the lungs are just from the dog, the euthanasia, and the dog, being on its side and whatnot. So the other thing, if you're interested in looking in the heart, you can actually remove the heart. I don't need to do that on this particular dog, but you can open that up and look. Sometimes we'll see heartworms in there. If they have heart disease, you definitely want to do that. We're just going to take a few samples. The liver looks normal. The spleen looks fine, but basically you go through the entire contents of the abdomen. This dog does have a great big bladder. Look at the spleen, make sure there's no masses on it. If there's anything that looks abnormal in color or consistency, you want to definitely take samples of that. So what we would do is, this is the spleen. So let's say there's a nodule here, then we would take a sample of that, and then we would put it in there for histopath. You can do different things on the intestines. You could take a punch biopsy and just biopsy, just do a little punch biopsy on that. But I would definitely recommend you get a full thickness, maybe a 4x4. And then you take that, and obviously each one of these samples has to be in a different container. And then we'll take a section of the spleen, and if the lesion is all throughout the organ, you can just take any little piece you want. If it's some type of a mass, then you need to obviously take the section where the mass is and get that sample. And again, for cultures, you can't use formaldehyde. That's not going to work. So you just have to find out from the lab what you would need to put that in. So that's basically how we do a necropsy. Depending on what needs to be done with this pet afterwards, we can just do just close this pet. If the owner wanted to take the remains home, just do a single layer closure, close up the abdomen and close up the skin. Or if they're going out for cremation, then just do a slight close, and then they can be bagged and ready to go to process remains. And that's it.
We perform vaginal cytologies to determine when an intact female is nearing or in the estrus cycle. When we perform the vaginal cytology, it helps us determine which cycle of estrus she is in. The first cycle of estrus is anestrus. It lasts less than 4.5 months. At this stage, we don't see any clinical signs of vulvular swelling. She's not attracting any males. We don't have any discharge. Microscopically, we'll see predominantly non-cornified squamous epithelial cells. We'll see some neutrophils and then no erythrocytes. Pro
Mid-estrus is the second stage. At this time, it lasts for about 9 days. We do see vulvular swelling, a little bit of reddish discharge, but she's not receptive to intact males ready to breed. In early proestrus, we'll see a high number of erythrocytes as well as basal and parabasal epithelial cells. The number of epithelial cells start to show signs of cornification, and then the number of erythrocytes starts to decline in late proestrus. Estrus is the third cycle. At this time, we'll see swollen vulva, a reddish discharge, and she is receptive to males. This stage lasts an average of 9 days. We'll see that the squamous epithelial cells are cornified and anuclear. First, we won't see any neutrophils microscopically, and then there will be a rapid increase in neutrophils as well as a decrease in erythrocytes. Mid-estrus is the fourth and final stage of estrus. It lasts about 2 to 3 months. At this time, clinically, she won't be attracting any males. She won't be receptive to breeding. There will be a decrease in the vulvular discharge as well as swelling. Microscopically, we'll see an abundance of cytologic debris as well as non-cornified epithelial cells. Sterile gauze, we have our gloves, our sterile cotton tip swab, our microscope cover slip, our glass microscope, and then we have a couple of our sterile sodium chloride syringes that we're going to be using to clean the vulva before we do our cytology. So we're going to put on our gloves first, and make sure not to let the tail drop after you clean the vulva, because then it'll contaminate your sample. Put some of our sterile saline on our sterile gauze, and then use that to wet the vulva. Before I get my hands dirty doing that, I'm going to just very lightly saturate our cotton tip swab with some saline. Okay, we'll set that aside. So with our vulva, what you want to do is just clean the outside and then try and clean a little bit of the inside as well. And this is in preparation of cytology collection, sample collection. So now that our patient's prepared, we are going to insert our cotton tip swab almost vertically, and then we're going to move horizontally, and then just very gently move it forward a little bit, and then just very gently we want to roll sample. So we've got our sample here. And then we're going to just very gently roll our vaginal sample here, that, and then put a cover slip on it and look at it under the microscope. Do our cytology stain for the vaginal sample that we got, and then we're going to do 10 dips, 15 dips, and 20 dips on our counter stain. Okay, and then
then we're going to rinse it off. Just very gently. And then just very gently blot. Okay, and then we're going to look at our cytology under the microscope. We are going to start out our lowest objective and then move to our final objective. So we're going to start at our 4 objective and focus in on our sample. Move to our 10x. Our 40x. Open our condenser to let more light through.
What you doing, Phoebe?
And then apply a drop of our immersion oil. And so our patient today, it was pregnant. We did spay her. So we are guessing that she's in metastress right now. We are seeing some non-quantified squamous epithelial cells. We're seeing quite a few neutrophils in here. Seeing quite a bit of cytologic debris as well. And then I'm also seeing some intermediate cells, but no erythrocytes. So we do believe that she's in the metastress cycle.
Cross-matching agglutination test is used for determining blood typing for dogs and cats who are considered for a blood transfusion. So we got our lavender top 2 blood labeled with our recipient Emerald, and then we have our serum separator tube as well. And it's really important to make sure that you properly label your tubes. So our donor dog is going to be Xenia, and we have a lavender top and then a serum separator tube. So we're going to centrifuge all of these tubes, and then at the end of our centrifugation, we're going to go ahead and continue with our cross-matching procedure. So we're going to come over here and make sure your centrifuge is balanced. So we're going to place the purple top tubes across from each other, as well as place our serum separator tubes across from each other. And then once that's done, we'll go ahead and continue. Okay, so we're going to add about 9 to 10 milliliters of our sodium chloride to our 2 drops of our centrifuge sample. Okay. Place our top back on the vacutainer, gently invert it a couple of times, and now we're ready to place this in the centrifuge. And we're going to repeat this process 2 more times, so we'll get started. Okay, now we are going to use 0.02 mLs of our
centrifuge sample. And then we are going to add 0.98 milliliters of the sodium chloride. So I'm going to remove all of what we do not need. Okay. Okay. So we are making our donor suspension right now. And then adding 0.98 mLs of sodium chloride. Going to gently invert. And then move on to our recipient suspension. Remove the supernatant just like we did for our donor. Again, take 0.02 mLs. Okay. Add 0.98 milliliters of sodium chloride. And gently invert. Okay. So now we have our recipient suspension. So what we'll do at this time is going to do our major and minor cross match. So we'll be taking 2 drops of our serum and then adding that to our clean new tube, as well as taking 2 drops of the donor's suspension and adding it to the same tube. Okay, so we'll add 2 drops of the donor suspension. we'll take 2 drops of the recipient's serum. Gently invert our sample to mix it. And then we will move on to our minor cross match. Okay, so for our minor cross match, we're going to be taking the recipient's suspension. We'll be taking 2 drops of the recipient suspension, placing it in our minor cross match clean tube. And then we'll take 2 drops of our donor's serum and place that in our tube labeled minor cross match. We'll gently invert. And then the final steps to this is we need to make 2 control tubes. So we're done with these. So what we're going to do is, instead of mixing the recipient suspension and the donor's serum, we're going to be mixing the recipient's suspension with the recipient's serum, and then the donor's suspension with the donor's serum. Okay, so we will do our donor control first. So we will take our new donor suspension and then our donor serum, and we'll do the same thing. We'll be adding 2 drops from each tube. Okay, we'll gently invert our control donor, and then we're going to make our control recipient. Okay, now that we have our controls established as well as our major and our minor cross match, we're going to let this sit here for 30 minutes to incubate at room temperature, and then we will perform our final steps of the cross match procedure. Now that our tubes have sat for 30 minutes, we are going to place each of them in the centrifuge for 1 minute, and then we will look at the tubes individually for any hemolysis or agglutination. You can stop filming. Okay, our centrifuge has finished spinning, so we're going to evaluate each of our tubes individually. We're going to examine the supernatant in each of our tubes for hemolysis, which is macroscopic agglutination. So we're just going to very gently tap on our tube here. I don't see any visible agglutination. We definitely should not have any agglutination in our control tubes. Okay. So I don't see any agglutination of the erythrocytes, so we're going to move to our next steps here, which is checking microscopically for agglutination. So I have each of our slides labeled: our recipient control, major cross-match, our donor control, and then our minor cross-match. So we are going to start with our recipient control here, and we're actually going to be using the supernatant and applying, transfer a small amount to the glass slide and examine it under low power. Okay. Start with our recipient. Find our recipient control slide, and we're just going to apply a small amount so that we can check for agglutination microscopically. Okay, and then we're going to move on to our major cross match. Do the same. On to our donor control. And last but not least, our minor cross match. So we are going to take each of our slides over to our microscope and look at them. Okay, we are going to put a cover slip on each of our slides, and then we'll take it over to our microscope and evaluate it for any agglutination.